Great, so welcome everyone and thank you for being here. I'm officially calling the meeting to order. It is 6:34 p.m. We're going to start with a roll call of members. Dr. Tyra Bryant-Stevens.
Here.
Dr. Jennifer Ibrahim.
Here.
Dr. Marla Gold.
Here.
Dr. Scott McNeil.
Here.
Dr. John Rich, I think, is not joining us. Dr. Amit Ismail.
Here.
Oh, great. And Dr. Ana Diaz-Rue. Great. Great, thank you all. So I'm going to turn now to Ben Hartung to explain the public comment process.
Thank you, Dr. Bedegal. Good evening, everyone. My name is Ben Hartung, and I'll be accepting and facilitating the public comment process for the meeting tonight. If you have a comment on either one of the regulations that are on the agenda this evening, you can place them in the chat feature using the GoToWebinar portal, or you could also email your comment directly to me, Benjamin, Benjamin .hartung@phila.gov, and I will post that comment in the chat for the board members to review. I will let you know that the board members are required to review your comment. They're not required to publicly deliberate about your comment at this time. And I also want to let everybody know that's joined the meeting that this is a meeting that's being recorded, both video and audio, and will be posted online after the meeting per city ordinance. So your participation from now on constitutes your consent to appear on that recording. Thank you.
And for those of you who might not have met him, I just wanted to introduce Dr. Frank Franklin, who is our relatively new still Deputy Commissioner and is joining us this evening. All right, so I'm going to review the agenda now. Have you had a chance to, I'm sorry, I'm going out of order. We will first review the meeting minutes. We'll then discuss a regulation relating to perinatal COVID-19 surveillance by the Division of Maternal, Child, and Family Health of the Philadelphia Department of Public Health. And then we'll discuss an emergency regulation governing the control and prevention of COVID-19, mandating vaccines for individuals working and dining at indoor dining locations. So I do at this point want to note that we received a request for a public hearing. So we believe it would be useful to amend the agenda to hold an executive session briefly for legal advice to the board. Well, I'll stop there and ask if there's a move to amend the agenda for that executive session.
So moved.
Second.
All in favor?
Aye.
Aye. Aye.
Any opposed? Okay, thank you. So we'll move briefly to executive session. For those who may be members of the public who may be listening, this should not be long. So if you stay on the line, you should be able to, we'll rejoin you shortly.
And I apologize, I now have to find out how to go into executive session. 1 second.
If anybody gets disconnected, please just give us a few minutes and call back in just in case.
And Dr. Bedegal, I apologize. I'm struggling to find the button to go out into executive session. But I'm trying. Unfortunately, I'm unable to do that at this point, I think. So I trying to figure out how we would move out into a breakout room.
So I think this is Joe Rosenberg-Altman. If the board is comfortable with it, I can just give a little bit of background. Just mention briefly the substance of the comment which the board has before it, and explain a little bit of the background of the normal process for city regulations, the emergency process that we've been following, and then the board can decide further if it is comfortable proceeding with respect to the emergency regulation right now, or if we need to further determine if we can get into an executive session to discuss further. And that'll give Ben some time to see if that's possible as well.
Thank you
Does
very
that sound
much.
good?
Yes, thank you.
Okay. So just to give a little bit of background, the normal provisions of the code, the normal regulatory process is that a department promulgates a regulation, a proposed regulation essentially, and that's either by the department or with respect to the Department of Health, it's the Board of Health that promulgates the regulations itself. So typically when the Board of Health promulgates a regulation, and we have two regulations tonight, one that's following the normal path and one that is identified as an emergency regulation. So with the regulation from the Division of Maternal Health that we will be considering, that regulation, once you adopt it at the board level, it goes and is filed with the Department of Records. It's filed with the Department of Records and it's advertised in a newspaper and it's there for 30 days. The public has 30 days to request a public hearing on that regulation. If no public hearing is requested, it then becomes a regulation and is effective after that 30-day period elapses, okay? If a hearing is requested, the board would then need to hold a hearing, hear the public comment, determine if they want to amend the regulation in any way or not, and then adopt essentially a report memorializing those decisions. That would be adopted at a board hearing, that report, excuse me, a board hearing, I meant a board meeting, just like this one. And then that would then be filed with the Department of Records, and then the regulation would not be effective until 10 days after that regulation. Excuse me, after that report is filed. The charter contemplates an emergency procedure if the mayor has declared that there's an emergency affecting the public health that essentially does not allow for that administrative process to take place. If following that administrative process would, further jeopardize the health of the public, then there can be essentially a regulation that's effective on a temporary basis while that process plays out. Okay, so what that means is essentially if you adopt something on an emergency basis under that regulation, you're making a decision that to delay for that normal process would be problematic for the public health. And in that case, the regulation can be effective immediately upon filing with the Department of Records. Now, that public process still takes place. Someone can still request a hearing, and in this case, we have a hearing request that has come in. But the regulation, that doesn't stop the regulation from being effective. Essentially, it's effective while the board considers any public hearing that then happens, and any report would then amend the regulation going forward. So the question is, I guess, both in general and for the board to consider, is whether whether the city can, whether you as a board can wait for that regulatory process to play out to put this in effect, or whether it's of an urgent nature. And I think, I know Dr. Bettingall will explain why it is of an urgent nature, why it is the health department's position that it's of an urgent nature, and that expedited process is necessary. The legal issue raised by the comment I think it's twofold, and you all have the comment before you, so I don't mean to, you know, I don't want to purport to say it's significant too much, but I think there's two concerns raised. One, that the public have an ability to comment. I think that is really the thrust of it. And two, the concern that the emergency procedure that the mayor has authorized has gone on too long because it's been for 22 months. And again, I think Dr. Bettingol and yourselves are in the best position, better than I am, quite frankly, to explain whether or not there is still a public health emergency of the nature that would require swift administrative action that perhaps can't wait that full 30, 40 or more days for action. That's the gist of it. I'm happy to talk further with you about it. I believe Dr. Bettingol will be, given that there's a public hearing requested, I believe Dr. Bettingol will be moving to hold a public hearing quickly to obtain any more public comment that can inform the board potentially even before the operative dates in the regulation, but certainly as soon as possible. And I'll leave it at that for now. Are there any questions that you're comfortable asking while we're in the public portion of the meeting? Does anyone feel the need for a further executive session at this point?
And I will just add that I've got some technical advice. If we believe there's an executive session needed, I think we can hop on a Teams call and just mute and turn off our cameras here. But I'll defer to whether or not we need that executive session after Joe's presentation there.
This is Ahmed Ismail. I don't think we need an executive session. We should proceed with the meeting and the two agenda items.
Scott McNeil, I agree.
Agreed.
I'd suggest you hold a formal vote since we did just vote to have an executive session, just
Yes,
to
that makes sense.
add that up.
Will somebody move that we not hold an executive session?
I move.
I'll second.
All in favor?
Aye.
Aye.
All opposed? I'm sorry for the awkward wording on that question. All right.
Joe, thank you for the explanation.
Yes, thank you, Joe. So I'm now going to move that we add to the agenda an item to allow the board to delegate the authority to hold the public hearing to the commissioner and whichever board members are able to attend to enable us to hold it quickly.
And to clarify, can you clarify which regulation the public hearing will be on?
I'm sorry, that would be about the emergency regulation. This is for the mandating vaccines for individuals working and dining at indoor dining locations. So do we have a move to add that to the agenda as an agenda item for tonight?
So moved.
The second,
Second.
all in favor?
Aye.
Aye.
Any opposed? Great, thank you all. So I'll now ask, have you all had a chance to review the meeting minutes? And do you have any questions about those? Is there a motion to approve the minutes?
So moved.
Great. The second,
Yes.
Second.
Ahmed.
all in favor?
Aye.
Aye.
Any opposed? Great. Thank you very much. All right, we're now going to turn to the regulations. Sorry for the bureaucracy this evening. But Joe, can you walk us through the perinatal regulation?
I actually
Doc-
believe there may be a presentation from one of the divisions and that Ben will be
Oh.
walking through the perinatal.
I'm so sorry, yes.
Thank you, Joe. Yes, Dr. Bettigol, we have Ayomide Sokale on the line to go give a short presentation to the board, and then I will walk through the text of the regulation after she's done. Ayomide, are you there? I will make you the presenter now if you're ready.
Yes, thank you. And Maria Huynh will also be presenting with me.
Oh, sorry about that. Hi, Maria. Ayomide, should I make your computer the one that's showing the presentation?
Yes, please. Hello, everyone. Can you see my screen?
Yes.
Yes.
Yep.
Hi, good evening, everyone. Today we'll be presenting on the perinatal COVID-19 surveillance project and the regulation pertaining to it. My name is Ayomide Shakali, and I am from the Division of Maternal, Child, and Family Health of the Philadelphia Department of Public Health.
And hello, everyone. My name is Maria Huynh. I also work at the Division of Maternal, Child, and Family Health. Ayomide and I both work on this surveillance project. Thank you for having us attend.
Thank you. And before we begin, we'd like to state that the goal of this presentation is to convey the importance of the proposed regulation as it pertains to data reporting and integrity in order to protect the health of pregnant persons and infants from the effects of COVID-19. Thank you.
And so we'll first talk about, the impact of COVID on pregnancy. And so since the discovery of COVID-19, a lot of people have been impacted, not only locally, but across the world. And with the information from COVID, we've also been able to identify at-risk or priority populations, which includes pregnant people. And some of the information we currently know about pregnant people and COVID-19 is that pregnant people are at an increased risk of developing severe illness when impacted or infected with COVID-19, and that COVID-19 infection during pregnancy has been associated with other associated risks such as preterm births, stillbirths, maternal hospitalizations, ICU admissions, and mechanical ventilation. And we feel that it is important to further understand the impact of COVID-19 infection during pregnancy as a new virus, and to support preventing the spread of COVID-19 specifically among pregnant people. So what is COVID-19, perinatal COVID-19 surveillance? This project is a public health surveillance project being conducted through the Division of Maternal, Child, and Family Health at the Health Department. We were first funded in August of 2020 by the CDC Centers of Disease Control and Prevention to really focus on gathering knowledge around what is the impact of this infection during pregnancy on birth outcomes, maternal health, and infant health outcomes locally, as well as contribute to the information nationwide. And so on the right, you can see a map of the jurisdictions that are also a part of this national surveillance effort. And this information is used to, first of all, provide more information on our understanding of how COVID-19 during pregnancy affects health. And several publications have been made to further our understanding, including the relationship between infection during pregnancy and severe illness among pregnant people, and the association of the infection on infant health, such as preterm birth and stillbirth. In addition to sort of publications, several toolkits have been developed focused on pediatric and OB providers, obstetricians, to work directly with pregnant people who might be at risk for COVID-19 infection. And then lastly, there has been a new website released by the CDC that presents this data publicly for those who are interested in understanding more about COVID-19 and pregnancy. The goals of the COVID-19, perinatal COVID-19 surveillance project for Philadelphia has 4 goals. The first one, which I think I've mentioned multiple times here, but is to further understand the impact of COVID-19 infection during pregnancy on birth outcomes, maternal health, and infant health outcomes. The second one is to quantify how many Philadelphians, specifically mothers and infants, are directly affected by COVID-19 due to exposure during pregnancy. And the last two are related to using this information to develop educational materials and trainings for different Philadelphia stakeholders who work directly with pregnant people and infants, and to inform the public on the effects of COVID infection during pregnancy.
So I will discuss the workflow for the perinatal COVID-19 surveillance project in more detail. So initially, cases are passively identified by the perinatal COVID-19 surveillance coordinator using existing PDPH data sources, and I will discuss these data sources in more detail later. Then data are imported into a secure REDCap database and de-identified and then submitted monthly to CDC's SetNet. Finally, aggregated data are presented to an internal PDPH team who identifies trends and patterns amongst those infected with COVID-19 during pregnancy. I would like to point out that this internal team consists of subject matter experts from the Division of Maternal, Child, and Family Health, as well as the Division of Disease Control. And finally, reports are generated and shared to promote policy and programmatic change. So currently, our data are collected from existing sources within PDPH. This includes vital statistics and primarily vital statistics birth data, as well as death data, and data for COVID-positive people from our communicable disease management system. And this is specific to people who are COVID-positive and live within the city of Philadelphia. From this data, we receive information needed for case identification. This can include the birthing person's name, their date of birth, the delivery hospital, and some demographic information and basic prenatal health information. On the infant side, we receive the infant's date of birth, often their weight and gestational age. And from the COVID side, we receive the COVID test result, the date of the test, and if symptom information is available, we may receive that as well. However, incomplete and/or inaccurate data can often leave critical gaps within the surveillance system. Some inaccuracies in data that we've noticed include missing maternal prenatal health information or maternal prenatal health information that is listed as a pregnancy-related condition such as gestational diabetes or preeclampsia when it was a pre-existing condition such as diabetes, pre-existing diabetes, or chronic hypertension. Inaccuracies in infant health include gestational age, so having a gestational age that is listed in vital stats that is inaccurate compared to what has been calculated. And the necessary data that we would need to be abstracted would include infant health information at the time of birth. So right now we have very limited information on the infant at the time of birth. So this information could include birth anomalies, as well as maternal COVID-19 treatment history, hospitalization, symptoms, and health conditions associated with the SARS-CoV-2 infection, just to name a few. And finally, in regards to infant follow-up, we do not have any information on the infant past the date of birth, and so this would include infant health information up to 24 months of age. So our proposed Board of Health regulation would allow for mandatory reporting of specific prenatal, postpartum, and infant medical record data. Right now, there are two proposed methods for doing this. In the first method, a clinical champion abstractor is identified from a hospital or health system to abstract and directly submit relevant data only pertaining to their hospital or health system. In the second method, PDPH MCFH will work with facilities without a designated abstractor to abstract relevant data within the division. Data will then be compiled and de-identified before being securely submitted monthly to CDC. And finally, this data set will be used for public health surveillance related to COVID-19 during the prenatal period, the postpartum period, and during infancy. We believe that this proposed regulation is important because without this regulation, PDPH will not be able to understand completely the impact of COVID-19 on the pregnant and recently parenting population in Philadelphia. This would allow us to provide appropriate prevention measures and support for pregnant and parenting people within the city as well, and provide information pertaining to and support for the infants who are exposed to SARS-CoV-2 in utero.
And lastly, we want to mention that the goal of our public health surveillance project is really to help build an infrastructure for a surveillance system in Philadelphia that focuses on future emerging threats for pregnant people and their infants. As we know through recent information that this virus is continually changing, and we want to be better prepared through building up systems to be more proactive than reactive.
Should we ask questions now?
Yes, I think
Okay.
so. Or unless Joe has to go through the regulation itself.
I can allow you to ask questions now, or I can walk through the text with you first before, however you prefer, board members.
Well, I have a question just about what you just shared with us. So you've been doing surveillance for a while, correct? And you're finding gaps. With what you found so far, has there been any action tied to that? Like, have you done anything in terms of prevention measures or any kind of proactive measures with the data that you have?
So the data that we have has been shared through to leadership at the different birthing hospitals at the beginning of, I would say like in the summer of 2020 when we first started. This is partly due to our medical officer of women's health having connections with each of the leadership at the birthing hospitals to allow for more, I guess, standardized prevention procedures across the birthing hospitals. And so that included making testing more consistent across all the hospitals. Yeah, so that's it.
Before we get into the text of the proposed reg, just a point, and it might be me, which is we're talking often about the impact on the pregnant person, the developing fetus, or some other kind of language, and infants, I assume. Not to mince, but I'm always thinking about how we word this when we're talking about impacts for women, developing fetus, and a newborn.
Yes.
I guess my last question probably is, how will increased surveillance lead to interventions? I mean, I think we definitely want to know what we can act on, but are there plans to like use this data as our path towards prevention with this data?
I think this is something we think about in terms of prevention for pregnant people, is that the strategies don't change too much from existing prevention strategies, which are to be vaccinated, to wear masks, to social distance, to isolate if positive. But I think our goal for this is, if we can get to a point where we are more actively identifying people, to be able to connect them immediately to services, specifically supports for the pregnant population. So that's where our goal is heading towards.
Okay, thank you.
You would,
Can I ask?
this is a question. Go ahead.
I was just going to say, just to follow up on the question about conversations with leadership at the hospitals, in addition to sharing the data with them, were there any requests or gaps that they're seeing or information that would help them to be more effective in terms of that translation piece?
I think for the most part, we've done 2 presentations with leadership at hospitals, but they haven't identified gaps more than the data has been reinforcing what they've been seeing sort of with their patients.
I think this is sort of implied in what you've said, but is a piece of what you're trying to get at better understanding the impact of COVID on the unborn infant and neonatal outcomes, and then potentially the outcomes, whether the outcomes are different with different COVID treatments. Is that correct?
Yes, and also at the timing of the COVID infection too, since we don't know enough about sort of if it's in the first trimester versus the last trimester, if there are differences there. So I think part of it is that there's still a lot of unknown on the timing of COVID infection and how it impacts maternal health and infant health.
So if I could, yes. So this is sort of chicken egg, cart horse kind of deal, because I assume that ACOG has not made a statement on prenatal testing or screening. In other words, this is surveillance of cases that happen to be known. This is because we're not adding this as a reportable entity. We're not providing guidance on screening because we're trying to gather information that says screening should happen. Is that right? This is downstream data that would inform policies looking for COVID, for example, as part of a collection of tests that we do on pregnant women at different trimesters, et cetera, because we have interventions later. So I'm just sort of saying, oh, so we're going to have this skewed, there'll be so many, unless it's already a screen when someone comes in to give birth, which I imagine it is. I'm just lost as to the N that we're finding and how we're finding them. Did I ask that horribly?
Oh,
I think
no.
I did.
No, sorry, that is correct. Like you stated before, we don't know much about how COVID may affect pregnant people and their infants differently. And so you're correct. It's kind of finding what we can now. In the future, that may be applied to different policy or programmatic changes in screening during pregnancy or possible interventions, or just contribute to knowledge.
Any other questions before we move to the regulation? And we can always circle back afterwards as well. All right. So
Thanks.
then
I'll make myself the presenter here. And I guess Ayomide and Maria, stay tuned. If there's any other questions, I can't answer, but let me know if this is zoomed in enough for you, board members.
It's good.
Thank you. So just briefly, the authority for this surveillance comes under the Pennsylvania Disease Control and Prevention Law. It also comes directly from the Philadelphia Code and from the regulations on reportable and communicable diseases, as well as HIPAA, the privacy rule, provides for disclosure of information to public health authorities under section 512B. So those are the legal authorities that the regulation is citing for the authority to collect this data. Again, the CDC SETNet, the Surveillance of Emerging Threats to Mothers and Babies program, is what is funding the Maternal, Child, and Family Health Division in this surveillance project. And we are targeting medical providers and facilities. And the definitions of those are facilities are all hospitals and medical facilities, where pregnant people may receive care, and a provider is a person or entity providing pediatric outpatient care to children less than 5 years of age. So that is the definition section, which also includes abstracted medical data, which refers to the process of changing raw medical records into limited data elements, which is basically pulling out the information that CDC is trying to collect and placing it into the REDCap servers. And this is done by people who are contracted with the Department of Public Health to do that. Those are the clinical champions that Ayomide and Maria referred to. There's also a definition here for perinatal COVID surveillance data, and it's defined currently as the full data dictionary that the CDC has provided to MCFH, which is Appendix A that was sent around to you for review prior to this meeting. And we have defined in the regulation that the data will not include any mental health or substance use treatment history. So the CDC is able to update the data dictionary requests, and we have included the definition to allow the data to evolve with what the CDC's requirements are, but that mental health and substance use data is a carve out that is permanent for the surveillance we're doing through the department. So section 2 explains the actual data request process, and it involves the division specifically reaching out to providers to request the data, and that data will come back in the form of the abstracted medical data on the REDCap forms, and this is done by a clinical champion or another third party that's directly contracted with the health department and has a confidentiality agreement with the division. And once that abstracted medical data is received, and it will be reviewed by the division and also will be transmitted to the CDC SetNet program, as was described in the presentation. And the final section here of the regulation is the confidentiality portion, and it states that the surveillance data will be maintained pursuant to 28 PA Code Section 27.5, and also according to the obligations under the Disease Control and Prevention Law. And we also include a requirement that any third party, and that's referring to the clinical champions or any other person who's abstracting the medical data, must have a user agreement with the Department of Public Health and the division to do that. And finally, the CDC has given its confidentiality letter for this project. So it is collected pursuant to the US Code confidentiality provisions. And this regulation will take effect after a 30-day comment period after it's given to the Board of Records. So that is the text of the regulation. Let me know if you have any questions. I apologize if you're coming up on my screen there.
So if there aren't any immediate questions, Ben, are there any public comments on this regulation?
There are, at this point, none that I have received for this regulation. I will give it a couple minutes because we do have a couple attendees in the webinar. So I'll give it a couple minutes here for anybody to have a comment in the chat if they'd like, and I will check my email as well.
Thank you.
I do have a quick question. You know, improved perinatal tracking has been a goal in the city of Philadelphia for probably 10 plus years. And
your
I know
screen is not showing with your email. Sorry, Scott.
That's okay. I think that's helpful.
Thank you very much.
Sorry, I didn't mean to interrupt. I thought it was important.
I thought I had clicked the button. I appreciate it.
No problem.
So I guess my question is, having worked with many of the chairs and birthing hospitals for data, and your gaps in data is not just around COVID, it's been gaps in data for many other reasons as well. So I guess my question is, are you tapping into data that's already being requested for perinatal tracking in general, or is this going to be separate that's specifically related to COVID? Because it seems to me that there's already a process in place to capture much of the data that you're asking for. And I know for at least, hospitals, but those also health centers like mine, where we do prenatal, perinatal, postpartum, I wouldn't want to see undue stress on reporting, additional reporting requirements when there's already been a desire to track a lot of the same information.
Do we have somebody from MCFH who'd like to address that question?
Yes. And so I think my understanding is a lot of the perinatal tracking is specific towards like topics such as maternal mortality or sort of like fetal and infant mortality, and that the current COVID-19 regulation doesn't allow us the authority to kind of ask about COVID-19 and pregnancy at the same time. And so I think that's where we had looked into seeing if this fell under another sort of regulation or authority, but it did not.
Okay, thank you.
If I can follow up on that, I mean, I think the related question is, what input do we have from the clinical settings that would be in this network about any burden of reporting, providing information that's placed on top of their current surveillance systems? I believe that's what Dr. McNeil was getting at, so I want to ask it as well.
Yes, well, we have been in contact with several of the birthing facilities to actually assign a designated person to be their clinical champion. And in that way, and we would be compensating them for their time. And so I think in that way, we were trying to mitigate some of the barriers and challenges on the clinical setting for reporting purposes.
Just a follow-up, which is the source of funding for compensation of their time?
So this would be funded through the CDC grant that also funds the surveillance project.
Okay.
I guess to follow up both of those questions, the data that you're collecting for this is different than the data you collect for other perinatal reasons. And you feel that the burden on the hospital or the birthing facilities is worth what we will learn from this data?
Yes.
Again, I have no negative reaction to this. I'm struggling with understanding why a CDC supported entity of a network translates to a board regulation. There's just it's some sense of it. As soon as you talked about funding those individuals and that it's federal funds, then I'm just struck by the need to have a board approved regulation for something that's gathering data for what might be a regulation for an intervention or standard report ad down the line. But I assume that that's what's needed here and that other participating cities are doing similar.
Well, and Marla, just to piggyback on that, the funding piece, so when the CDC funding runs out and this reg is still in place, there's a gap there in terms of the burden on the data collection. I guess the other question I had is I was just looking to see within the CDC who else is collecting. And so we've got not Delaware, but we've got New York, Pennsylvania, New Jersey, Maryland. And so are there any conversations about looking, sort of regionally and being able to look at the data beyond just the direct data that we're collecting right here? What's the plan for that?
Yes, sorry, I think I can answer both of those questions. To respond to the first question, We really wanted to make sure we weren't adding additional work for these hospitals or health systems. That is why at this time we're not requiring active reporting. If cases are identified passively in a health system and we have a clinical champion identified, then that person would be responsible for abstracting the necessary data. However, if we don't have a clinical champion identified, it is not necessary for the hospital to provide one if they cannot, and we would be abstracting that data in-house. So we really wanted to make sure that the burden was not on the health system. And then for the second question, sorry, we have had discussions with New Jersey and Pennsylvania State, specifically Pennsylvania State, about looking at our 2020 infections, so our 2020 cohort in Philadelphia and Pennsylvania. And at some point in the near future, hopefully in the next year, combining that data to look at the impact in Pennsylvania as a whole.
And again, I'm sorry, I know we have more pressing things. There's not a question about I have no question about the importance of this. I'm trying to understand why a Board of Health regulation is needed to be part of this entity, which is the CDC's funding participation by several major cities in the surveillance network. That's all. Because once we do it, then it has a life of its own, as Dr. Ibrahim's just pointed out. And so that's what I'm struggling with. Not the idea, but why this avenue in order to do it.
So this is Joe Rosenberger, Altman, just to jump in for a second. And folks from the department, please correct me if I'm misstating this. One, is the thought that the CDC funding would require the reporting already to a different entity other than the Board of Health? Or is the thought else? What is the thought that the regulation wouldn't be necessary because the CDC funding would require it? Is that the idea?
Yeah, that participating in the network is a given and that the city agrees and has a surveillance setup. So again, I'm so cognizant of tonight's agenda. I don't question Philadelphia's participation in this. I support this fully. It's the mechanism that has me questioning it. That's all, as to why that's needed, because there are plenty of things that are similar to this that come down from the CDC or come over from the CDC from time to time anyway, that we participate in as a major city that is going to give outcome data. So this is a regulation, and it is not, there's no screening on purpose, there's no anything other than we're regulating to give us the data, but we're compensating the people who are giving us the data. So I may be missing something, and I'm going to stop now. I just got a little confused.
So I'm just going to note two things, and honestly, I don't understand the CDC funding or programmatic piece as well as you all do, so I might be missing the mark. But I know that from a privacy review perspective, with in the city law department, I know that if we're getting the data, there was certainly a desire to make sure that whatever we were getting was the most narrow data possible, for example, to protect the privacy of individuals, and that the information was subject to some kind of confidentiality that was memorialized in some way. So I can say that part. The other piece that I would indicate is that I do believe there's at least one other program that's connected to CDC funding that the that the Department of Health is involved in, that I know came up in the discussions of this regulation, and I think that has to do with Zika. So I think that that has this isn't the only time there has been a regulation, and I know that the confidentiality pieces were pieces that are important. As far as the requiring of reporting, I can't unfortunately weigh in too much on that. To know if there's a better mechanism for it.
Are there other questions right now? And Ben, did any questions come up in the chat?
I have not seen any questions. Let me just double check my email now that my screen is not being shared, and I have not received any emails about this either.
So I guess the only other question that I would have is with regards to the duration of the reg. And so if we're saying that this is something that's going to be supported by CDC funding, is that something that we want to include in terms of the duration of the reg, contingent upon? Because if we're saying that CDC is going to provide the funding for this, thereby removing the financial burden for the institution, if that funding is no longer there, it goes back, Dr. Brian Stevens, to what you had said, are we placing an undue, or Dr. McNeil, maybe it was you who said, are we placing an undue burden? If we don't have a clinical champion, then do we have this in place and it's not something that can actually be implemented? That's the one thing that I think I would feel more comfortable if that's what we're saying. It feels more consistent if we say that it's contingent, the life of the reg is contingent upon the CDC funding.
So we would be, sorry, go ahead.
Oh, no, you please go ahead, Dr. Bennett.
I was just going to ask, so we'd be amending it to add something to the effect that this would be in effect as long as the CDC funding for this study was ongoing. That way, if there's rollover funding, we don't have to amend
Correct.
for the rollover fund. Does that work?
I would suggest, just so we have a definitive date, having it until the commissioner certifies to the board that the CDC funding is no longer in place, so that there's an act certain that happens and then it terminates. Otherwise, it can be a little confusing. We've done that before. And then I would suggest, to the extent that amendment is going to be made, in addition to moving for that amendment, I would suggest also moving to allow the commissioner discretion to implement administrative changes associated with that regulation, that amendment.
And Joe, can you remind me, do we need to ask the board to vote on both of those amendments first before they vote on the regulation, or after?
I don't know about the order. I think, I don't know that the order matters. I think either is fine.
You have to vote on the amendment first.
Mm-hmm.
Okay. So, Joe, are we voting on one amendment or two amendments?
You're voting on one amendment, and then you're also voting, also I'd recommend a vote to give you delegate authority to implement it administratively, just in case periods, commas, sections need to be, slightly adjusted, just those minor changes.
Okay. So do we have a move for the amendment?
I move both amendments.
This is Jen, I'll second.
All in favor?
Aye.
Aye.
Any opposed? Okay. And to delegate authority for administrative changes?
I'll make the motion.
Second.
Second.
All in favor?
Aye.
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 Any opposed? And for the regulation itself, is there a
I
motion?
move to
Is there a second?
Second, this is Jen.
All in favor?
Aye.
Aye.
Any opposed? Thank you very much. All right.
That was worth the discussion. I feel much more comfortable with that.
Yeah, thank you all. And I apologize that we have a lot on our agenda tonight. There's just a lot happening. So we will now move to the next agenda item, which is the emergency regulation governing the control and prevention of COVID-19, mandating vaccines for individuals working and dining at indoor dining locations. So before we walk through the regulation itself, I wanted to say a little bit about why we're doing this regulation in this kind of rushed way. Like, why not do this in the same way that we're doing the previous regulation with the 30-day comment period, kind of in due order. So the reason that we moved in this direction We had been at a pretty steady state with around 200 cases a day, hospitalizations pretty level, the mask mandate essentially seeming to keep things in check along with vaccines. And then Thanksgiving happened and cold weather happened. And, you know, I think I had been worried and lots of us had been worried because when you looked at parts of the country where it had gotten cold, case rates were skyrocketing, even in places that actually have a high vaccination rate. What we've seen in Philadelphia since Thanksgiving, though, was a very big difference. A doubling, we doubled our cases in 6 days. Hospitalizations have increased pretty sharply. And what's happening around us is much worse. So Philadelphia has actually had the lowest case rate of the southeastern Pennsylvania area. I found it recently also the lowest case rate of any county in Pennsylvania. I talked to Allison Beam trying to understand, you know, where we're at for hospitalizations around the state. And there was a period a few days back when a whole section of South Central PA went on divert for 4 hours, which, you know, is kind of at that point meaningless because there's nowhere for hospitals to send people if they're on divert. You know, not a good situation. Our hospitals, as you all probably know, are quite full at the moment, not necessarily of people with COVID, but of people with lots of other things, mental health concerns, RSV, everything, plus COVID. But the big increase in COVID-related disease, including hospitalizations, was very concerning. And so we realized that if we went with the usual process and the 30-day notice and then the 10 days, we were going to be in a position where we'd be too late. At least we'd be very late and potentially in a situation where the hospital's overwhelmed. So that's the reason for the abbreviated process. And I do think, you know, I really, really value the input of this board, and I don't want, and public input in general, which makes what we do stronger. You know, we did have a series of stakeholder meetings that I think helped us to make things stronger and better, but that isn't the same as general public input. So, you know, it's kind of where we are with this pandemic. We keep getting hit with waves in between. It looks like things are better. With the high vaccination rate, you know, it had hoped not to hit another wave of this sort, but it looks like here we are. And we have at least a handful of Omicron cases in the city now. So we'll see where we go with that. But with that, if there aren't any immediate questions, I can turn things over to Joe, or actually, is it Joe or Ben who's walking us through the regulation?
So I will walk you through the regulation, although I do not have, I don't have the technical expertise to share my screen. So Ben, if you want to do that, or if board members, if you have the regulation before you, you can let us know what would be helpful to you.
Yeah, if Ben, if you're able to share your screen, we do have some members of the public on the call, and I'd like people to be able to see it as well as hear the description.
Great.
That will take me 1 second. I'll do that briefly.
Thank you.
While that's being worked on, I just want to quickly go on record as saying that I don't believe that this is rushed at all. I think as much as thought that you in your leadership, Commissioner, and others who worked on this can be doing under these circumstances of still being in a post-Thanksgiving bump, more winter holidays and New Year's right in front of us, and looking at what's happening, for example, in Great Britain, London, you know, that's headed our way. So I feel, just from what we talked about earlier, we didn't need for executive session, that there's an urgent need, soon emergent need to have this before us. And I appreciate that it's here. Thank you.
Thank you.
Can everyone see my screen now?
Yes, thanks.
Yes.
Okay, so I'm just going to summarize the whereas clauses very shortly. We've seen these before. This is an emergency regulation, which, as we discussed earlier in the meeting, will mean that it will be effective before the normal 30-day comment period and any public hearings play out. There is some delay built into the regulation to put folks on notice. So while it'll be effective immediately when posted with records, if this board adopts it, the earliest, I think, what I would call an operative date is going to be January 3rd. So let me scroll down. The board, of course, is promulgating this regulation pursuant to the Disease Control and Prevention Law, various provisions of the Philadelphia Code and Charter, and consistent with the mayor's declaration of extraordinary circumstance, suspending the formal regulatory process for regulations concerning COVID-19. So we have some definitions. Most of these should be familiar to you. They're very consistent with the board's prior regulations. There's two newer, well, three newer terms, but two terms that we've used somewhat in the past that are a little different now. One, we've used fully vaccinated before. Now we're using completed vaccination series. This is essentially means that the person has received either 1 or 2 doses of an approved COVID-19 vaccine, but it doesn't include the subsequent 2-week waiting period that would be needed for a person to be considered fully vaccinated. And also for when we talk about outdoors in the past, we've talked about locations that are open on 3 or more sides. That has been changed to 2 or more sides to provide a little bit more flexibility. And so I'm going to talk real briefly through this indoor dining location, since this is essentially where the vaccine mandate will apply. So an indoor dining location is any location, whether open to the public or private, that includes personal residences where food or drink is sold or served indoors for consumption on site, except as follows. And we'll talk a little bit about the personal residences later, because that's only very limited circumstances where it applies in that setting. But the term does not include a location where only drinking water is served or permitted, early childhood education and K through 12 schools, hospitals, congregate care facilities, or other residential or healthcare facilities, any location where food or drink is consumed as part of a religious practice, a location where food or drink is sold exclusively by vending machine, and that doesn't include a designated indoor eating area, any portion of a location that is outdoors, meaning that the area is fully open to the outside on 2 or more sides, provided that entrance into any associated indoor food or drink service or eating areas must be actively monitored to ensure compliance with the regulation. If there's a business or a commercial location where an indoor eating area is entirely segregated from other portions of the facility, so long as that portion of the indoor area, eating area portion, is monitored, all other portions of the facility are not considered indoor dining. For food courts or markets and airport facilities, there's specific rules that are a little bit more complicated that we'll get to below. And finally, it excludes food service locations that provide free food to those who may be homeless or in urgent need of food, such as a soup kitchen. Indoor dining worker is any individual that works in an indoor dining location or in any capacity. And then the general rule will be that effective January 3rd, no business that serves or provide food in an indoor location shall allow individuals on site unless they comply with the vaccination requirements set forth in this section. And the subsequent sections, there's section 3 deals with indoor dining workers, section 4 deals with customers and other non-indoor dining workers, section 5 with requirements for athletes, performers, and supporting staff. So indoor dining workers, effective, this is a very brief summary, and then I'll get into a few more details when we go below. But this is a very just overall summary. So effective January 3rd, indoor dining workers must have received at least 1 dose of an approved COVID-19 vaccine, and if applicable, by February 3rd must have received the 2nd dose. And there's some exemptions again that we'll discuss below, medical and religious exemptions. Diners and other non-indoor dining workers that are 12 years of age and over, effective January 3rd, must have received a completed vaccination series. So whether that's 1 or 2 shots, depending on the vaccine. Diners, 5 years and 3 months of age and over, but under 12 years. So these are the folks that are under 12 essentially, but do qualify for a vaccine right now. Effective January 3rd, such diners must have received at least 1 dose of an approved COVID-19 vaccine, and effective February 3rd, 2022, such diners must have received a completed vaccination series. Diners under 5 years and 3 months are exempt from the requirements of the regulation at this time. There's a section as we go down that clarifies that if the vaccine becomes available for younger age groups, then the requirements of this regulation will, or some of the vaccination specific requirements of the regulation will kick in. Athletes, performers, and support staff are subject to the details of the safety plans approved by the department for the relevant facility. Nothing in this regulation applies to indoor dining locations when individuals, are present for a short duration, something like less than 15 minutes for the purpose of picking up food to take out, using a restroom, or for a similarly shorter transitory purpose, provided the individual is masked at all times. This regulation also doesn't preclude in any way a business from establishing a more strict vaccine requirements. There are restaurants right now that are that only allow folks that are vaccinated, and there are various other laws that those establishments must make sure they're complying with. But to the extent they can do that, that is fine for them to do. This is a floor, not a ceiling, as we say in other contexts. So I'm going to actually just stop there for a second to see if there's any questions before I go on to talk about application in specific situations. If there's any more broad questions. Okay, I'm going to go on then. I know this is a lot of information, so I apologize. I'll try to hit the highlights. So with respect to grocery stores and food courts and similar locations, so areas where there's a lot of takeout food essentially, but there's some areas for eating on site. The general rule is that it doesn't apply to the portions of the facilities that are just takeout service, and it would only apply to areas of a facility where customers can sit down and eat. And those areas must be cordoned off, and screening must be provided to prevent access to those who don't comply with the vaccination requirements. And anyone workers that serve those areas of the dining area would also need to be vaccinated. And then to the extent at some food courts there's I'll say on-premises dining, where there's maybe a small amount of seating directly at the premises. In that circumstance, both the seating where customers can eat and the dining workers that serve those customers would be subject to the vaccination requirements. With respect to the airport, it's especially complicated because if you're familiar with it, there's lots of different areas and different types of eating areas. And of course, people are traveling, and so there's not necessarily an ability to eat outside, and there's not necessarily an ability to abstain from eating indoors in any way. So there's a modified rule in this venue. So it only applies to a location that provides a restaurant-style indoor seating area that is used for consumption of food or beverages sold by such establishment, and that is enclosed from other areas of the airport on 3 or more sides. And customers and staff of such establishments will need to comply with the vaccination requirements. Any establishment that provides bar-style seating service and counter service, so similar to those food court circumstances where we were talking about, where there's kind of on-site seating right there, and there's service directly to the customers. customers and staff at those facilities would likewise need to comply. With respect to indoor dining locations that seat over 1,000 customers, so these are going to be situations like an indoor sports stadium, for example, where eating is permitted in the seats, and there's more than 1,000 customers that could potentially be dining indoors. Any unvaccinated individual that's over 5 years and 3 months of age that qualifies for an exemption or is temporarily accepted from the regulation must submit proof of a negative PCR or antigen test for COVID-19 from a sample from such individual that was collected within 24 hours preceding the individual's entrance into the indoor dining location. And we talked that with respect to private event spaces or private homes, the rule is that if the gathering is over 25 or more individuals, then all attendees must have received either a completed vaccination series or qualify for an exemption under the regulation. And there's one last detail, which is that prior to January 17th, a business may choose to accept a negative COVID test, a negative PCR antigen test from an individual within 24 hours of the date of entrance, and that's any facility, instead of requiring an individual to provide the vaccination status or to claim an exemption, and that expires January 17th, 2022. So the rules that we're talking about in Section 3 are very similar to those that were provided above, so I'm just going to skip basically to the exemptions here, unless there's any further question. But for indoor dining workers, to receive a medical exemption or a religious exemption, the individual must submit certain documentation and they must agree to abide by the accommodations that are required by the business. So for a medical examination, the indoor dining worker must submit a certification and must submit a certification from a medical provider that has examined the person in person on at least one occasion, certifying that the exemption applies, and indicating the reason that the vaccine is contraindicated for the indoor dining worker, specifically that why the administration would be detrimental to the health of the indoor dining worker. And the certifications must be signed pursuant to the requirements and penalties of Section 1108 of the Philadelphia Code, which essentially says that verifications must be truthful or they're subject to a penalty under the code, which is typically $300. Religious exemptions are signed just by the worker and certifies in writing that such individual has a sincerely held belief that precludes such worker from receiving the COVID-19 vaccine, and that a philosophical, moral, or other non-religious objections will not be accepted. The Department of Health is going to post forms that can be used for this purpose. And as far as accommodations, there must be weekly testing, double masking, so either a cloth mask with a tightly fitted over a properly fitted surgical mask, or a well-fitted respirator equivalent to an N95, or if feasible, allowing an indoor dining worker to engage with the business virtually so that they don't come into contact with other workers or customers. Indoor dining locations, the businesses subject to the regulation will be required to maintain documentation regarding vaccination status, exemption, and certifications submitted related to indoor dining workers, and including the ongoing testing. With respect to individuals, so customers and others that are not indoor dining workers, the medical exemption and the religious exemption documentation is very similar. It needs to be submitted and signed both by the individual that's requesting the exemption for the medical exemption and by a licensed healthcare provider. So a nurse, nurse practitioner, physician's assistant, licensed by an authorized state licensing board, who has conducted an in-person physical examination of the individual on at least one occasion that certifies that receiving any approved COVID-19 vaccine would be detrimental to the health of the individual, and that they have been medically advised not to receive the vaccine. The certification will include certain information, and again, there will be a form on the department's website. The religious exemption is very similar to the exemption that we discussed above. There aren't documentation requirements regarding the exemptions for customers. Given the nature of it, it needs to be shown, but it doesn't need to be maintained by the business. So for children under 12, we talked about this a little bit earlier. Children who, well, an individual in any age group for which there's no COVID-19 vaccine that's been approved, which is currently under 5 years of age, is not subject to the vaccination requirements of this regulation until such individual has qualified for vaccination for at least 3 months. So if the age for vaccination is lowered, after 3 months, individuals will be required to comply with the vaccination provisions of this section. And then there is the delayed effective date that we talked about earlier. So as of January 3rd, individuals between 5 and 3 months of age that are under 12 years of age only need to have one COVID vaccination shot by January 3rd, and they need to have the second by February 3rd to enter into the indoor dining location. Athletes, performers, and supporting staff are not subject to the regulation, but must strictly comply with a safety plan approved by the department for the facility at issue. So those areas may operate only pursuant to those safety plans. Section 6 just talks about how the businesses can rely on documentation, including observably credible records of vaccination status provided by an individual, copies or pictures of a CDC vaccination card or state or authorized local government issued vaccination card, certifications provided that are consistent with the regulation, and individuals that are 18 years old or older must provide a photo identification so identity can be confirmed. Stricter regulations are permitted, as we discussed above, and the Department of Health can inspect the documentations that's required to be maintained by the businesses subject to the regulations. Then we're talking about individual liability for falsely submitting certifications that we talked about previously, and penalties on businesses, which may be heightened in accordance with one of the board's earlier regulations pertaining to fines and penalties. The regulation will be in effect until rescinded, superseded, or amended by further order or regulation. The City of Philadelphia's emergency regulations, as this board knows, are revisited very frequently. So this board has both implemented new regulations and rolled back prior regulations that were no longer necessary on a very frequent basis. And the commissioner is also authorized to roll back regulations between board meetings if she sees fit pursuant to prior Board of Health regulations. The Department of Health is also directed to promulgate guidance by order or otherwise to interpret and otherwise implement the requirements of this regulation. And as discussed previously, this regulation will be effective immediately upon the filing of this regulation with the Department of Records.
Thank you,
Are there
Jo.
any questions? Sure. Sorry, I know that was a lot of information.
I have a comment about I agree with everything that was said and all the regulation and the rationale for it. The only thing that I have reservations about is really page 2 and 5, referring to personal residence, private residence. I think this is an overreach to dictate what people do in their homes. So that's the only concern I have about the regulation.
Yeah, I will say that our intent is not to go into people's houses and disrupt, their dinners. The idea is if somebody's holding, say, a large wedding, for example, at a personal property, to be able to have some sway there, or a catered event is probably a better example there at a private facility. But
that's almost that's almost impossible to enforce. It's impossible to enforce anything that happens in the homes of people.
Yeah, I mean, you could imagine a private catered event on a very large scale, for example.
I just wanted to flag as well that, I mean, this is consistent with the thought that enforcement would be unlikely, but the requirements for documentation and so on only apply to businesses. So the portion of the regulation directed to private homes is more instructive, I think, as opposed to set up in a manner that would be, for enforcement purposes.
I'd like to ask, even though it's late, I have to, in constructing this, I assume that consultation with the cities that have such regulations was done, and then obviously adapted to our city. So there are probably answers to a lot of these. We're not the first, and we won't be the last to have this. Commissioner, is it possible to comment a little bit on the experience of other cities? Like, just as you gather up your thoughts on that, when I saw private event spaces in homes, while I only wish, that everyone understood and said about vaccination, my concern was that if we appeared to be going into personal homes with regulations, that we would lose people following other regulations, and that something could backfire. But I have to assume that there's experience, in fact, in real time coming in from other cities that are ahead of us on this. Might you comment overall of what actually happens when these things go into effect, to the best of your knowledge?
Sure. And so the place I'm most familiar with and have communicated with Commissioner about is New York City, where this has actually been very smooth. I think the mayor talked a little bit about that the other day, but they put this in place. This dates back more than a month, I think, but they only had a requirement for one dose at that time. They are starting a requirement for the second dose on December 27th. But it seems to work fine. Restaurants have gotten used to it there. And we actually had one of the restaurant owners who spoke to the press about our proposed regulation, said he owns restaurants in New York and it actually has gone fine there. The difference here would be that we would be starting with the 2 doses approximately the same time as New York, but it's the same idea. People have to show some kind of proof of vaccine, and it could be a vaccine card, it could be a photo on their phone of their vaccine card, it could be an app. There are a number of commercial apps. We are not creating our own app. I don't know if anybody saw what happened when New York created theirs at first, but we don't. You could upload a picture of a cat. Like we would rather not go there. But there are multiple apps, and any kind of reasonable way of checking vaccine status would be acceptable, along with some kind of photo ID for people who are 18 and over. So it has gone smoothly. The precedent for the private residence is actually here in Philadelphia. That was in an earlier regulation. It was stricter. I forget the exact number, but it was smaller than 25. There were very few situations where environmental health did go, where there was a gigantic party, everyone unmasked, and they did go and say, folks, this is not an okay thing to do. In general, we're not looking to go into private homes, but you could imagine at a very large private space, an event of hundreds of people could be a super spreader event. So, you know, I've learned never to say never, but the goal wouldn't be to be in people's private spaces.
And I think the value of it being instructive is something not to be missed, because folks may wonder, like, what is safe? You know, it's the holidays, you know, so giving them kind of some kind of frame of reference is also helpful.
The other, please, if others have questions, let me pause for a second. I don't want to. The only other area, and I appreciate the chance to just clarify this, is we have already passed a regulation for healthcare places as well as institutions of higher ed that stipulates what they should do with exempted individuals. So let's take a healthcare institution for a minute. Their cafeterias are subject now to a different regulation for exempted, and I just get this overlap of the exemptions and what applies to who and where within those entities already regulated. And I'm not self-serving on this. I really want to just even that out.
Yeah, and no, it's useful to clarify because this is large scale and it's complicated. So this does not apply in healthcare institutions. Doesn't apply in congregate care institutions or K through 12 or early child care schools, daycare. For colleges and universities, there are sites where it does apply, right? So places where, you know, for example, the arenas, if they're serving food, would be similar to the Wells Fargo Center. If it's seating 1,000 or more, then it would be subject to the testing for exempts. And I know that's been a point of, I wouldn't say contention, but certainly discussion with colleges and universities. For dining halls, they're under 1,000. As far as I can tell, I haven't come across a college or a university that has a dining hall with more than 1,000 people in it, and therefore the testing wouldn't be required in that setting. Colleges and universities already have a vaccine mandate. What am I leaving out?
No, I think that clarifies it a little more, and hopefully once we move forward, I'm sure there'll be more simplified explanatory documents and guidance coming out. They're probably being written up moving forward, because I think of it as the life of an exempted person. So in Philadelphia,
right.
and following them through. And so that was I guess my other quick question, and it's quick, is the experience then of New York. Will we, after the 17th of January for adults, is it still going to be that they can show some form of a document and say they're exempted and get into a Sixers game, for example? How does that work? Who's reading that?
Right. So if it's a Sixers game, they would have to do two things. They'd have to show either for a medical exemption, something signed by a licensed practitioner. For a religious exemption, it's something they sign saying that they have a sincerely held religious belief against vaccination. And then we're posting some standard forms, not that people have to use our forms, but that was one of the requests from the business community, was to, you know, have something that they could just print out. So that'll be posted. If it's a Sixers game or anything else that has 1,000 or more seats, they'd also have to show a negative COVID test within 24 hours. So the Sixers could decide to do on-site rapids, or they could just, you know, have that be a requirement at the door that people show that. That's only for people with exemptions.
Right. And these places could decide, by the way it's written, to only allow vaccinated people in and forego all of this, correct?
Yes.
I would just mention that we have received 3 comments, well, a comment and 2 series of questions. I've posted them in the chat. I can also forward them by email to the board members if you're not seeing them in the chat, but I just wanted to give you time to review and respond to those.
And this is Joe. I just want to make sure we're looking for the right number. I'm seeing 3 comments/questions total, 2 from one person and 1 from a second person. Is that right?
That's correct.
Does anybody need more time to read through the comments or questions?
I want to note that as we're sitting here, I'm sure it's now over 800,000 Americans have died. 1 out of 100 seniors, I guess it was reported to have passed from COVID. That over 80% of people that are hospitalized seriously are fully unvaccinated individuals. And that as a member and all of us on the Board of Health, the first and foremost responsibility is to protect the health of the citizens of Philadelphia. And I believe that this regulation is a big piece of that.
Thank you, Marla. Yes, the notification about the 800,000 deaths just came out. Are there any other questions from the board or any comments that you wanted to engage with further? Hearing none, is there a move to approve the regulation?
Move to approve.
Second.
All in favor?
Aye.
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 Any opposed? Thank you all very, very much. Thank you to the members of the public who attended. And we will be, I believe, reaching out to schedule a time for the public hearing as quickly as we can get it on the calendar, and we'll put out notifications about that.
Dr. Medical, I do think we still have, to the extent the agenda was amended to allow for a vote to delegate, but I don't think we actually had that vote. I did want to flag that.
Thank you. Thank you very much. Yes, is there a move to delegate the authority to hold that hearing to the commissioner and whichever members of the board are able to attend?
I move.
Second?
Second.
All in favor?
Aye.
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 Any opposed? Thank you. All right. Is there, Joe, any remaining business that I've left out?
I believe that is it. And just to make sure everyone understands, the regulation that was just referred to in the last motion was specifically the emergency regulation for indoor dining that we just discussed. Correct. Everyone is on the same page.
Yes.
Thank you once again. It really is incredible service that you guys provide for you professionals provide for the city of Philadelphia, and I'm truly grateful. This meeting is now adjourned. It is 8:09 p.m.
Thank you.
you.
Thanks. Take care, everyone.
Take care.
Thank you all. Good
Good
evening.
night.
Holiday.
Thank you. I'll be ending the broadcast now. Thank you.